Hello, everyone. Good evening, or good afternoon, or good morning, wherever you are. But we welcome you to what we term the Evening with the Experts, which is part of our 21st annual Indie Hematology Review. My name is Dr. Ruemu Birhiray. I'm the program chair. And what I intend to do today is walk you through some of the most amazing data that was presented at the American Society of Hematology meeting in San Diego this past December, and also other major meetings over the past year. So the title of my talk is State of the Art 2024, Emerging Therapies in Hematologic Malignancies and Disorders. These are my conflicts of interest, companies that I speak for or that I've done business with. So I'd like to start out by talking about acute myeloid leukemia. And this is a pretty busy slide, but I'll walk you through it. Acute myeloid leukemia is the most common acute leukemia that you will see in adult men or women. And it's a disease that is usually associated with a very poor prognosis. For most patients, we like to treat them aggressively upfront if we can. And then as patients get older, that becomes impossible. When patients are treated and they relapse, then frequently it's very difficult to treat them. So at the American Society of Hematology meeting this past December, there were a lot of data that were presented. First, for a type of acute myeloid leukemia, which is referred to as acute promyelocytic leukemia, which is a very uncommon type of acute leukemia, but very easily treatable, or readily more treatable than the others. I won't say easily treatable. This is a disease where the current standard of care uses a vitamin A analog that is called all-trans-retinoic acid, in addition to arsenic trioxide. So remember the old arsenic that we doctors used to give in the old times. It's back, and we use this oral combination in addition to vitamin C to treat patients. And what these investigators did was to look at the combination of vitamin C, this vitamin A analog, and arsenic as the only treatment without giving chemotherapy in patients with newly diagnosed acute promyelocytic leukemia. And what they did was they did a risk adaptive strategy, which means that patients who were considered low risk didn't get any chemotherapy, and then patients who were high risk got chemotherapy with just one chemotherapy medicine called daunorubicin. And what it did was then to look at 3 years to see the outcomes. And what you see is that 97% of the patients who were treated were alive and free of relapse at the end of 3 years. So that is really very exciting to be able to give this treatment. For some patients, no chemo, and for some other patients, very minimal chemotherapy to see these kind of outcomes for a disease that is difficult to treat. Another type of disease are patients who would have relapsed. So there is a group of patients who would have relapsed, and they have a second mutation, which is called KMT2. And KMT2 is present in about 20% of acute myeloid leukemias. And there is an oral drug called revumenib, which belongs to a new class of drugs, which are called menin inhibitors. And these drugs, given an oral form, have been shown to be quite effective in the treatment of this disease. So studies have been presented to show this. And the main study that was presented at ASH was a study where they looked at 94 patients, and they gave this drug, and 23% of those patients responded very well. And of those patients who responded, about half of them were able to go on to transplant and have very long remissions for a disease that is very difficult to treat. So we expect that this drug will be approved by the Food and Drug Administration anytime now. That is the most advanced member of this class of drugs. But there are other members of the class, and there's a Johnson & Johnson drug or J&J drug that was looked at. And this drug, also given orally, they treated 58 patients, showed significant activity. About 63% of those patients demonstrated some degree of reduction of their acute myeloid leukemia in their bone marrow. Another type of acute myeloid leukemia is patients who are older or who are not candidates for chemotherapy. Currently, the drug that is approved is a drug called venetoclax, and it's typically given with very low-dose chemotherapy, either a drug called decitabine or a drug called azacitidine. And those are typically given to patients who are not good candidates for very aggressive chemotherapy. But we know that those drugs do work, but eventually patients relapse. So what else can we do? One of the studies that looked at a strategy is to identify a group of patients who have a mutation called FLT3 ITD mutations. And those patients, when given a combination of an oral drug called quizartinib, in addition to venetoclax, which I talked about earlier, which is a drug that sends a signal to the cells that the cells must die, in addition to very minimal chemotherapy, showed that 65% of those patients responded. And these were patients who had not been treated previously. So this is very encouraging and potentially could be an addition to what we normally do, which is the two-drug combination. Another drug combination is a drug called selinexor, which is an oral drug that, again, is a chaperone of proteins, the proteins that tell cells to die are chaperoned into the nucleus, activated so that those cells can die. And when given in combination with venetoclax and azacitidine in a group of patients who have previously been treated with chemotherapy, what they found was that about 80% of those patients responded. Again, another strategy of trying to treat patients who were newly diagnosed to try to overcome the relative resistance or their likelihood of relapsing. Another combination of this was called the so-called Cyclax regimen. And what they did was they used the drug venetoclax and the drug selinexor in addition to chemotherapy using a regimen called FLAG, which is a very well-established regimen. And they gave this combination and they found about 42% of the patients who were treated achieved a complete remission. Then similarly, going back to that menin inhibitor we talked about earlier, menin inhibitor was given in addition to an oral chemotherapy called decitabine, and then with venetoclax, and given that combination, a very small study showed that 100% of the patients responded when this combination was given to patients who have relapsed acute myeloid leukemia. So the message here is there are new drugs that are coming out. Some of them will be approved very soon, or some of them are already approved. For example, the drug selinexor is approved for multiple myeloma, but when given in combination to drugs that are already being used in acute myeloid leukemia, can overcome the relative resistance of those patients and offer new therapeutic options for our patients. What are patients with acute lymphoblastic leukemia, which is another type of leukemia, or potentially using immunotherapy in acute myeloid leukemia? There's a drug called sabatolimab, which is a drug that sends a signal to it inhibits a protein that sends a signal to the immune system that tells the immune system, do not kill me. And by activating this protein called TIM3, it results in the immune system being activated. And in patients who have had an allogeneic transplant, where we're concerned about graft-versus-host disease, you have to be very careful to give them an immune stimulator. In this particular study, they gave the immune stimulator sabatolimab, and they found that there wasn't an increased risk of graft-versus-host disease, but they also saw that sabatolimab was able to improve the length of time that patients live when compared to what you would have normally expected. So again, another strategy of using the immune system being activated with this drug in acute myeloid leukemia. And other studies have looked at acute lymphoblastic leukemia, which is a disease that is really very common in younger people and less common in older people. For the longest time, we knew that patients who were older did not do as well as young people. And part of it is that the pediatricians are smarter than us adult oncologists. But besides that, frankly, the truth is that they treated those patients very aggressively. So we borrowed from those physicians who treat pediatric patients regimens that are adapted for patients between the age of 16 and 31. And what we found is if you go and look at those studies where we gave the same aggressive regimens that we would have given to very young patients, to these patients who are adolescents or young adults up to the age of 31, you find that they do just as well as if they had received it as children. So again, reinforcing the fact that using those very aggressive pediatric regimens can overcome some of the relative resistance that we see in this particular disease state. Another drug that has been used is a drug called nerandomilast. Nerandomilast is a drug that inhibits T cells. And so the promise was that if we was given in combination with chemotherapy, for patients who have a T-cell lymphoblastic leukemia, that it would result in improvement in outcomes. And unfortunately, that study was negative. That study did not show an improvement. So that is a drug that probably will not be used in that disease state. But another drug combination that was used in patients with, again, this type of T-cell lymphoblastic leukemia was to use the same nelarabine, but combine it with a drug that is typically used in B-cell leukemias, which is called asparaginase and venetoclax, in addition to a regimen called hyper-CVAD. And what they found was that at 3 years, 76% to 88% of those patients were alive and had not relapsed. So very encouraging. So probably nelarabine using the appropriate combination can have evidence of activity in T-cell lymphoblastic leukemia, which is a very difficult type of leukemia or lymphoma to treat. Another study was to use a drug called blinatumomab. Blinatumomab is a drug that is currently approved for the treatment of patients who would have received treatment for acute lymphoblastic leukemia. And if they have evidence of residual disease that was found by PCR, then you could give them blinatumomab, which is an immune activator. It's a drug that engages the immune system in a very specific way. It grabs the T cells of the immune system and grabs the leukemia cells and brings them together in a matchmaking manner. And when this combination is given, what we found was that 76% of the patients who were treated achieved a complete response, and about a third of those patients had a molecular response, which means that the disease wasn't detectable when used in these patients with B-cell acute lymphoblastic leukemia, newly diagnosed with blinatumomab. So again, very reduced dose of chemotherapy with blinatumomab showing efficacy in this disease state. So those are the stories for acute lymphoma, for acute myeloid leukemia, acute lymphoblastic leukemia. Myelodysplastic syndrome is a disease where patients do not have leukemia, but they are on their way to developing leukemia. We used to call it pre-leukemia, but that terminology is no longer in favor. But we know that one of the manifestations that the patients present with anemia, a lot of the times we'll give them medications to stimulate the production of red cells. And so there are drugs which we call erythropoietin stimulating agents, like Procreate, like RNS were the drugs that we used to use. And so this drug called luspatercept is a drug that essentially mops up all the inflammatory proteins, or at least one of the most significant inflammatory protein that is responsible for the anemia. And by mopping it up, the patient's red cells are released and are able to then generate normal red cells. And when that was compared to erythropoietin stimulating agents, these patients with myelodysplastic syndrome, this drug was superior. So luspatercept is now approved for those patients and is superior to erythropoietin stimulating agents in patients with low-risk myelodysplastic syndrome. Another drug is called imetelstat. Imetelstat is another tyrosine kinase inhibitor, and it's a drug that inhibits a protein called telomerase. We think telomerase is the protein that tells cells to die, and when you inhibit those cells, the cells are basically reactivated and no longer go on to die. And using that drug in patients with low-risk myelodysplastic syndrome was also superior to erythropoietin stimulating agents. And so those two studies, the COMMAND study and the EMERGE study, which you can see in this little graph that I have here, you could see that these patients had an improvement in their red cells, which is the what you see on the red here, and similarly on the blue are the patients who were treated with the drug called imetelstat. And both of these drugs are approved by the Food and Drug Administration for the treatment of these diseases. Chronic myeloid leukemia, or CML, is a disease that is currently treated with oral drugs, the so-called tyrosine kinase inhibitors, but now we have a new drug. There's a new drug called asciminib, and asciminib inhibits the tyrosine kinase, which is called BCR-ABL, at a different spot. It's currently approved for the treatment of patients who would have failed first-line therapy. And in this particular study, they took 101 patients and gave asciminib as frontline therapy. And what they found was that the patients achieved a very good response. And at 12 months, about a third of the patients had had disappearance of their leukemia that wasn't detectable at all using this one drug. So again, telling us that newer drugs might be just as effective or potentially more effective than the old drugs that we have. And the advantage of reaching that goal is that potentially patients could go off therapy in the future. another study, which was called the Ask for More study. They took 84 patients who were treated with initial first-generation tyrosine kinase inhibitors, but when they didn't respond as well, then they were then treated with asciminib, and they were able to overcome the relative resistance of those patients. Another disease, which is called large granular cell leukemia, is a very rare disease. There's not a standard of care. A lot of the times we use a drug called methotrexate, or sometimes we use a drug called cyclophosphamide, but when patients fail, no one really knows what to do. So a drug called ruxolitinib, which is used for myeloproliferative neoplasms, was used, and we found that patients, about a quarter of those patients had complete responses. So again, this is a regimen that is coming to place near ours. What are lymphomas? We're going to talk about Hodgkin's and indolent lymphomas, and I'm going to share some data with you. So there was a study called the Simpatico study where they looked at mantle cell lymphoma, and they used a drug called ibrutinib, which is approved for the treatment of CLL, in addition to a drug called venetoclax, which is also approved for the treatment of CLL, versus ibrutinib, which was also approved for the treatment of CLL in the past, for mantle cell lymphoma in the past. And using this combination of ibrutinib and venetoclax, they found that patients who've been treated with mantle cell lymphoma who failed chemotherapy, some of them had failed an autologous stem cell transplant or even allogeneic transplant potentially, 54% of these patients had a better response compared to what you would see, complete disappearance of tumor, when you give the I plus V regimen compared to I alone. And the time to next treatment was also significantly longer. And this translated to a significant improvement in outcomes, which you can see here, looking at the blue versus the orange, which are the two curves. And then in mantle cell lymphoma, another drug, which is another Bruton tyrosine kinase inhibitor called zanubrutinib, in addition to an anti-CD20 called obinutuzumab, and then venetoclax again, was used for newly diagnosed patients with mantle cell lymphoma, especially the most difficult group of patients who have a p53 mutation, and this combination was shown to have an 88% complete metabolic response, where there was total disappearance of disease on PET CT scanning. And in another type of indolent lymphoma called follicular lymphoma, the T-cell engager called mosunetuzumab was given. This is a drug that grabs the T cells and grabs CD20, which is present on follicular lymphomas. And when this drug, which is now approved for later lines, was given in the first line without any chemotherapy, 96% of those patients responded. In Hodgkin's lymphoma, one of the most exciting studies that was presented at the American Society of Hematology and also at the American Society of Clinical Oncology, ASCO, in June of last year, was a SWOG 1826 study where the drug nivolumab, which is an immune stimulator, was given with chemotherapy, a regimen called AVD, versus a more aggressive chemotherapy and immunotherapy called brentuximab AVD, showed that there was a significant improvement in the likelihood of achieving a complete remission and the risk of relapse, which was improved by as much as 52% by giving this combination. And this is a study that was really unique because the number of minority patients that were enrolled was 25%, which shows that we can do these studies in the United States. And this, what you see in this data set, is the difference between two groups of patients when you look at the likelihood of dying or progressing. And the blue are the patients treated with the nivolumab AVD regimen versus the red, which are the patients treated with the BV AVD regimen, showing the superiority of the nivolumab or immunotherapy combination regimen. And when this was also looked at in older patients, older than 60, they found that it was better tolerated and also more efficacious in that group of patients. Using the same concept, they use this nivolumab, which is the immune stimulator, with the antibody drug conjugate called brentuximab vedotin and chemotherapy in early stage Hodgkin's lymphoma. And what you will find is that 95% of these patients achieve the complete remission at the end of therapy. Another rare disease, which is not really a lymphoma and is not also a myeloma, is a disease that is very aggressive. It's called blastic plasmacytoid dendritic cell neoplasm. And this is a disease that's very difficult to treat. Previously, we used to give chemotherapy, and with chemotherapy, patients only live for 18 to 14 months. In the past year, there's a new drug that was approved by the Food and Drug Administration, which is an antibody drug conjugate, and it's called tagrax, tagrascofosp, or TAG, which is the easier way to call it. You could say that it's a tongue twister, and it took me 3 tries to call it. And this drug, when looked at compared to what you would expect with chemotherapy, you see that the overall survival was 20 months versus what you would normally expect with chemotherapy, showing that this is a regimen that is here to stay. It's approved by the Food and Drug Administration and its current standard of care. In aggressive lymphomas, when patients fail standard of care, options are very limited. So the regimen that was looked at is from the group at the National Cancer Institute is the VIPOR regimen, where they looked at venetoclax and ibrutinib with prednisone and obinutuzumab and lenalidomide, the regimen called VIPOR. And for a group of patients who failed multiple lines of therapy, you find that the 2-year survival was about 36% of the patients were alive, and about 40% of the patients achieved a complete remission. So that's a very encouraging regimen, and that's a regimen that should not be too expensive, relatively speaking. Another regimen, though, is immune engagers. So there's a drug called dronextamab. It's a drug used in relapse refractory lymphoma. They did a final analysis and again showed that about half of the patients achieved a complete response, or at least a response, and a third of them was a complete response with durable responses. A similar drug that's already approved is called epcoritamab, which is another immune engager, combined with a drug called lenalidomide, was found to have a response rate of about 72%, with about 52% of those patients achieving a complete response, better than what you would expect to see with epcoritamab alone. So using the drug lenalidomide, which is approved for multiple myeloma and lymphoma, enhances the immune efficacy of this drug called epcoritamab. Another drug is called glofitamab. Glofitamab is also an immune engager given with the standard chemotherapy that we use for diffuse large B-cell lymphoma called R-CHOP. In this very small study of 24 patients, they found that 93% of the patients exhibited an overall response rate. So very encouraging results showing that our treatment for these diseases are evolving and new therapies are becoming available. And then finally, it is a very rare type of leukemia, which is intravascular B-cell lymphoma. Most of these patients, no one really knows how best to treat them. And using an old drug called methotrexate, given a high dose, was found to be quite efficacious. 73% of the patients having a response, and those responses not progressing. And the overall survival was about 85% of the patients. So this is very encouraging when you look at the patients who were treated with high-dose methotrexate with this regimen. And then T-cell lymphomas are difficult to treat. When patients relapse, it's difficult to know what is the best thing. Here they use an oral drug which inhibits a protein called EZH1 and EZH2. This drug, which is not approved yet, is called valemetostat. And when given to patients, they gave it to 148 patients. They found out that 43.7% of them responded, and this included all types of T-cell lymphomas, and about 8.4% of those patients went on and got an allogeneic transplant, presumably longer duration of response. So again, very encouraging using an oral drug for a disease that's difficult to treat. There's an EZH1 drug that is already approved for the treatment of follicular lymphomas, but this drug, valemetostat, is currently not approved, and it's an EZH1 and 2 inhibitor. In multiple myeloma, the anti-CD38 antibodies, which are currently in the market, have been now shown in 2 studies that were presented at the American Society of Hematology meeting to have significant activity in the first-line setting. The first study was a study where they used a drug called isatuximab, which is an anti-CD38 antibody. They gave it to 300 patients, a phase 3 study, and then they also gave it both initially and then in consolidation. And what they wanted to look at was the likelihood of achieving what is called undetectable minimal residual disease status. That means you're not able to detect one myeloma cell out of out of a million myelomas, out of a million white blood cells. And what they found was that by using this drug called isatuximab compared to chemotherapy alone, without isatuximab, 67% of the patients achieved that undetectable minimal residual disease negative status. And that's what you see here. So the blue patients, I'm looking for my cursor here. The blue patients here are the patients who were treated with the isatuximab, and the orange were the patients who did not. And you can see across the board, those patients, irrespective of risk status, did very well. The study that was also another study that was presented, which I consider a practice-changing study, something that we all had been doing, was to use the drug called daratumumab with a chemotherapy backbone of VRD for multiple myeloma versus VRD alone in patients who were transplant eligible. And what they found was that by giving this drug, daratumumab, which is an anti-CD38 antibody, you find that the likelihood of achieving a complete response was 87.9% versus 70.1%. And again, not being able to detect myeloma cells out of 1 in 100,000 cells was 75.2% versus 47.5%. And it also showed that the likelihood of progressing was significantly improved. And you can see the difference here, 84.3% versus 67.7%, which is what you see on the graph on the right-hand side. So again, cementing the use of these anti-CD38 antibodies in treatment of multiple myeloma in the frontline setting. Another regimen was to use the drug daratumumab in patients who have smoldering myeloma. These are patients that typically are not treated. Given a single agent, daratumumab showed significant activity with a median overall response, with a median survival of 84 months in these patients who were treated with single agent daratumumab. Another combination that is really unique is a group of patients. This is very common, especially in African American patients, particularly men, who have this translocation 11-14 myeloma. This is a difficult to treat myeloma, but when you give them this drug called venetoclax with a drug called daratumumab, which I just talked about in dexamethasone, compared to not giving any venetoclax, you see that the patients do very well. The venetoclax significantly improves outcomes with a progression-free survival rate of 73.4% versus 38.8% for the patients not treated with the venetoclax combination. The likelihood of having minimal residual disease undetectable status was also way improved, 38% versus 8%. In multiple myeloma, also there is now there are multiple drugs which are drugs that activate the immune system, and one of them is a drug called talquetamab. Talquetamab is a drug that, when combined with a drug called pomalidomide, which is now used in multiple myeloma. In this phase 1 study, they look at 35 patients using this immune engager talquetamab. They found that this talquetamab significantly improved outcomes compared to what you will see with talquetamab alone. And about 86.7% of those patients responded. The likelihood of achieving a complete response was 60%, and the likelihood of achieving a very good partial response was also significantly improved, with most of these patients doing very well, including patients who've had CAR T therapy, which is supposed to be the most effective potential treatment for myeloma. So really very encouraging results in treatment of multiple myeloma. Other diseases that we must not forget about are these myeloproliferative neoplasms. These are uncommon diseases, and the most common is myelofibrosis. The drug that is typically used is ruxolitinib, and we've been using ruxolitinib now for at least 10 years. But frequently, patients will progress or will not respond to ruxolitinib. So the question is, can we add other drugs to ruxolitinib and make ruxolitinib more effective? And this has been shown. And so studies that were presented at the American Society of Clinical Oncology included using a drug called navitoclax, which is a drug that tells the cells to die, with ruxolitinib, which is superior to what you would normally expect with ruxolitinib. And similarly, a drug called pelabresib, which is a BET inhibitor, another protein that is mutated in the pathway, combined with ruxolitinib was better than ruxolitinib alone. And then using an LSD1 inhibitor, and I promise you it's not the drug, it's LSD1 as a protein that is present in this pathway, in combination with ruxolitinib, was also better than what you would normally see with ruxolitinib. A study where they tried to look at ruxolitinib in a group of patients who have polycythemia vera did not show a significant improvement in disease control compared to ruxolitinib, but they did find that there was improvement of symptoms relative to what you would expect with standard of care only in these patients as first-line therapy with high-risk polycythemia vera. And the LSD1 inhibitor was also used in essential thrombocytosis in patients who were resistant to standard of care, typically hydroxyurea. And what they found was that there was a favorable response in terms of change in patient symptomatology. Other diseases that were also presented data for were chronic lymphocytic leukemia, Waldenstrom's macroglobulinemia, and amyloidosis. In chronic lymphocytic leukemia, the drug ibrutinib plus venetoclax was looked at and was found to be quite effective and potentially better than what you would expect with ibrutinib only. And this is time limited, where patients were treated for duration of time that was based on whether they achieved what is called MRD negative status. Again, another combination that could be quite effective when compared to chemotherapy in this group of patients. CAR T therapy using the so-called lysocell was also found to be effective in refractory patients with CLL. And then pirtobrutinib is a Lilly drug, which is now approved for the patients who have relapsed mantle cell lymphoma, and also patients who've had the old classic drugs, the first generation and second generation BTKIs, again showing that this is a drug that has efficacy in the treatment of this group of patients. Acalabrutinib is a drug that's approved for the treatment of CLL and also for mantle cell lymphoma, and it was looked at in patients who have Waldenstrom's macroglobulinemia or patients presenting with a type of neuropathy which is associated with either full-blown Waldenstrom's or it's kind of a spectrum of Waldenstrom's called MAG-mediated IgM peripheral neuropathy, and this showed a significant improvement in neuropathy symptomatology. And then CAR T therapy in patients with Waldenstrom's macroglobulinemia who had transformed, again, showed evidence of response with about 68% of those patients responding. And then in amyloidosis, which is a disease where misfolded proteins are deposited, it's sometimes part of myeloma, and a lot of the times these proteins are deposited on the heart, on the lungs, and they use a drug called KAL-101, which is an anti-myeloma monoclonal antibody protein, in addition to treating the underlying plasma cell disease, and they found that patients' heart functions improve, and there were evidence of improvement of their cardiac function. Again, suggesting that there might be better ways of treating amyloidosis, which is a difficult disease to treat. And in terms of stem cell transplantation, just some data sets that I would like to bring to your attention. This past December, 2 drugs were approved. One of them was gene therapy for sickle cell disease using Levocell, which is a gene therapy product that is made with the lentivirus. And that showed that there was an improvement in terms of sickle cell. Patients were no longer needed transfusions, resolution of veno-occlusive disease associated with sickle cell. But another exciting one was to use this new technology called CRISPR to edit the DNA, take the patient's own stem cells, edit them, and modify them so that they can produce a different kind of red cell. Typically, you switch it so that they can begin to produce more hemoglobin F, which is fetal hemoglobin, and this decreases the symptoms of sickle cell disease, and those 2 drugs are now approved for the treatment of sickle cell anemia using those strategies. Additionally, just using the old haploidentical, that means you take someone who is half a match to the recipient with sickle cell disease, and using that as a way of treating their sickle cell disease, find that at 2 years, 95% of those patients were able to achieve disease control of their sickle cell disease. In multiple myeloma, using double transplants in patients with high-risk myeloma appears to continue to show efficacy. And then in chronic graft-versus-host disease, which is one of the main reasons why we don't like to do allogeneic transplantation, because of the attack of the patient's immune system on the recipient, using this drug called isatulimab, which is an antibody targeting a protein called CS1, was found to be quite effective in treating chronic graft-versus-host disease. Additionally, there is a drug, which is a JAK inhibitor, which is called itacitinib, and itacitinib was found to decrease the likelihood of having cytokine release syndrome, which is a condition associated with the use of CAR T therapy in the treatment of lymphomas. And so using this drug prevent the likelihood of developing cytokine release syndrome or another condition called ICANS, which is a neurologic syndrome. And I think this is a potential game changer in the treatment of patients who will need to receive CAR T therapy in the future. In this not so-called benign hematology, optimizing hydroxyurea in patients with sickle cell disease continues to be quite effective. That is cheap, it's simple, and optimizing it so that patients adequately and aggressively treated can decrease the complications associated with sickle cell disease. And in paroxysmal nocturnal hemoglobinemia, which is hemoglobinuria rather, which is a disease that's not very common. Currently, we use an anti-complement antibody. Several of them approved, but using new oral drugs targeting other parts of the complement pathway, for example, the drug danicopan targeted factor D, or the drug iptacopan, which targets factor B, are both found to enhance the efficacy of the so-called C5 inhibitors, which are the antibodies that we currently use for PNH. Another study was to look at patients with severe hemophilia using a different kind of inhibitor. Was found to decrease the likelihood of severe bleeding, and especially patients who have inhibitors and are not able to receive factor. And a drug called hereditary hemorrhagic telangiectasia, or this is a disease where pomalidomide, which is a drug used for multiple myeloma, reduces the bleeding that's associated with this disease, which can be very difficult to treat, and for which there's not a standard of care. So just to finish out, I know I spoke a lot and I tried to speak as fast as I could. There are a lot of practice-changing drugs that are coming down the pike. Revumenib in the treatment of acute myeloid leukemia, nivolumab in addition to chemotherapy for Hodgkin's lymphoma, and daratumumab for the treatment of multiple myeloma. And then if you want to look at fixed duration therapy for CLL, this combination of ibrutinib and venetoclax, rather than maybe venetoclax and obinutuzumab could be a potential combination that we should think about. And then gene therapy for sickle cell disease, either using the viral gene therapy or using the CRISPR gene therapy for the treatment of sickle cell disease, or using an allogeneic transplant from half a donor, and also enhancing the treatment of PNH by use of these oral drugs in combination with the antibodies. And in the treatment of myelodysplastic neoplasms, using drugs that work beyond ruxolitinib or the so-called JAK inhibitors, for example, navitoclax and pelabresib, which I just talked about. And then I also talked about luspatercept, which enhances, superior to the use of growth factors in patients with anemia with myelodysplastic syndrome or imetelstat, and ixatinib, used for graft-versus-host disease, as we found, isartilumab rather, not ixatinib. Isartilumab is a drug which is an antibody targeting CSF1, and it promotes significant improvement in outcomes in patients with chronic graft-versus-host disease. Those are practice-changing. Potentially practice-changing would include antibodies, isatuximab in the treatment of multiple myeloma, the use of the I plus V combination in mantle cell lymphoma in patients who would have relapsed, the use of the tissue factor pathway inhibitor for severe hemophilia, and also the use of a different kind of pathway for CML, and then pomalidomide in hereditary hemorrhagic telangiectasia. Practice confirming the use of drugs like glofitamab, epcoritamab, mosunetuzumab, and odronextamab, and then also the antibodies like teclistamab, larentumab, talquetamab in treatment of multiple myeloma, and blinatumomab in treatment of ALL. And we should stay tuned for use of selinexor in acute myelogenous leukemia, itacitinib in treatment of prevention of ICANS and CRS in patients who need CAR T therapy, or potentially bispecific antibody therapy, and the use of CAR T therapy in the treatment of patients with transfer water-response macroglobulinemia, and the use of the anti-myeloid monoclonal antibody KL101 combined with anaplasma cell therapy for patients with light chain amyloidosis, and valemetostat, the EZH1 inhibitor in the treatment of T-cell lymphomas. So I hope this hasn't been too long, but I look forward to talking to you guys next time, hopefully live at our next meeting, which will be on March the 8th of 2024. So thank you for listening, and God bless.